I am pleased to welcome you all today to a forum to discuss the impact of blast overpressure and the need to better protect our service members. All three of my brothers served in the military, so supporting our active duty service members and our veterans is personal to me. Service members put their lives on the line, and in return, we have a duty to do all that we can to keep them safe, to protect them from unnecessary risks, and to get them the care that they deserve. I am proud to have been fighting for our troops and our veterans since I first came to Congress. Since I joined the Senate Armed Services Committee 8 years ago, I have been able to expand those efforts. I am especially proud of the work we have done under the Biden-Harris administration. Veterans fought for over a decade to get care after they were exposed to burn pits that made them sick. Senate Democrats and President Biden and Vice President Harris actually got it done. We passed the PACT Act to expand VA health care and benefits for those veterans, as well as veterans from our previous wars who were exposed to toxic substances like Agent Orange. To date, this has delivered life-saving care and benefits to more than 1 million veterans and their families. Private partners like Home Base are also helping us keep our promises to service members and veterans. Last February, we celebrated federal funding that I helped secure to support Home Base's work with Special Operations Forces with traumatic brain injury. This money has also been used to help families of the fallen and to strengthen resilience in children from military families. So far, we have managed to get a total of $15 million for programs like Home Base, and it's either available or somewhere in the pipeline at this point. Today's forum will focus on the work that DoD and Home Base are doing to address blast overpressure. Just a reminder for those who are not working in the field, blast overpressure is the pressure resulting from a shock wave that exceeds normal atmospheric pressure. Traumatic brain injuries are considered one of the signature wounds of our wars in Afghanistan and Iraq. Traumatic brain injuries and other injuries resulting from blast overpressure may come from roadside bombs, but far more often, TBI comes instead from the service members firing their own weapons. Much of this exposure is not in combat, but in training right here at home. The consequences of blast exposure have been devastating. Suicide, depression, seizures, and more. To see just how these blasts damage service members' brains, the New York Times recently provided a helpful demonstration. It involves just a couple of items, a beer bottle filled with water and a mallet. And I want to play this because I think it's a way for people to get a deeper understanding of what blast overpressure means, that it's not just a bump like getting hit on the arm, that it's something very different. So we've got a video for that. Could we play the video, please?
There's this old party trick where you can take a full beer bottle and smack the top and blow out the bottom of the glass. Scientists who study the physics of blast waves think something similar is happening in the brain. We're going to hit the top of a beer bottle with a mallet, and that should send a shock wave down through the liquid inside. The shock wave is going to go down through the liquid, and when it bounces off the glass on the bottom, it creates a very brief vacuum. In that vacuum, water vapor turns to bubbles. And when those bubbles expand suddenly and then implode, boom, the glass breaks. This is what a growing number of scientists think happens when a blast wave hits the brain. Just like a beer, the brain is largely water. And just like a beer, the brain is surrounded by a hard case. In this case, it's not a bottle, it's the skull. Also, just like the beer, the damage in the brain seems to happen not where the hit actually happens, but on the other side where the wave bounces back. If that theory is correct,
then the damage would be found anywhere there's a change in the stiffness or density of the tissue that would reflect the shock wave.
And in fact, that is exactly what scientists have found in autopsies of brains that were repeatedly exposed to blasts.
The next time you have a beer, you can think about your brain. Addressing blast overpressure has been a critical priority of mine over the last 7 years. I've worked closely with Senator Ernst on this issue, and I held a hearing on it in February in my role as chair of the Senate Armed Services Personnel Subcommittee. I also introduced the bipartisan, bicameral Blast Overpressure Safety Act with several colleagues, and I've secured several provisions from this bill in the fiscal year 2025 National Defense Authorization Act. I am very pleased that last month the Department of Defense released a new policy to address these critical issues. For today's forum, I want to focus on 3 issues. First, we need to use every tool we have to give service members access to the care they deserve. Home base is one of our most powerful providers. Their comprehensive brain health and trauma treatment program returns 95% of service members back into the field. It also engages family members in the process so they are able to get the support they need and better able to help a loved one. Second, we must understand the long-term effects of this exposure to blast overpressure. Brain injuries may be only part of the story. Special operations forces such as Green Berets and Navy SEALs are one of the communities at highest risk for blast overpressure. Doctors are starting to see special operators with rates of above-the-neck tumors and cancers that are higher than they would otherwise expect. These numbers are preliminary, but the pattern is truly alarming. They make clear that we need to explore the long-term consequences of exposure so that we can better understand what we're up against. And I will be pushing Congress hard to support this work. Third, we need to do a better job of mitigating the risks of suicide after extensive blast overpressure exposure. In late June, the New York Times reported that a DoD lab, quote, found distinctive damage from repeated blast exposure in every brain it tested of Navy SEALs who had died by suicide. We need to do a better job to help those at greatest risk and to help family members recognize when service members are in crisis and need help. So, to our panelists, welcome. Thank you very much for appearing. I am very pleased to have an opportunity to welcome Dr. David Smith, who is Deputy Assistant Secretary of Defense for Health Readiness Policy and Oversight, Kathy Lee, Director of Warfighter Brain Health Policy at DoD, Dr. Ross Zafont, Chief of Traumatic Brain Injury and Health and Wellness Programs at Home Base, and Dennis Hernandez, a former Green Beret in the Army Special Forces who received critical care at Home Base. So, Dr. Smith, I believe you're going to give us some opening remarks.
Yes, ma'am.
I recognize you for that then, please.
Well, thank you very much. And I want to just, first of all, say thank you, and it's an honor to be here, and to thank you, Senator Warren, for your advocacy in this space, along with your colleagues, because your continued engagement with the department and the Congress is just a critical piece to this. But protecting warfighter brain health, of course, for the DoD is the top priority, and first to take care of our people, of course, but also to ensure our military is operationally ready for whatever the country calls it to do. As an overview, we take a comprehensive approach to warfighter brain health initiative across the department. We start with research and data collection to inform clinical practice, understand causes and impacts, and better predict who will be impacted in what ways and under what circumstances. And over the last nearly 10 years, we've been intensively studying the blast overpressure, including characterization of blast overpressure associated with our various weapon systems. Even as we continue to learn more, we are starting to put in place measures to prevent excessive blast exposure and associated injuries. We have developed a field guide and tools to promote awareness and planning for training evolutions to minimize exposures, and it's written in a way that is readily relatable in the field and understandable, I think, and we've been hearing all sorts of positive comments about that. We also seek to rapidly detect the injuries and cognitive impacts that do occur in order to enable treatment that can help mitigate future health impacts. And an example of that is, I think you're aware, we've been doing pre-deployment cognitive testing since 2008, but are now implementing periodic cognitive testing and monitoring across the force. And we seek to improve health outcomes through updating treatment protocols and training of our military medical providers and professionals as we get new information. And a good example is in May, the Traumatic Brain Injury Center of Excellence launched a smartphone app for care for our providers called the Warfighter Brain Health Provider Toolkit. And that's a one-stop shop for tools and resources to assist with assessment, evaluation, and treatment of mild TBIs at the point of injury and beyond. So building on this strategic approach, we aim to take rapid and decisive action to better manage the risks of blast overpressure. As you know, military operations are very complex endeavors, and we know we are asking our service members to step into harm's way with that understanding and trust that we will do everything we can to protect them. So you mentioned one of our new initiatives, and I want to highlight, is the policy that was just signed out by Deputy Secretary of Defense Hicks last month that sets the department-wide requirements for action to mitigate and track blast overpressure exposures. Our intent in the policy is the establishment of, we have this interim blast overpressure exposure safety guidance, and we call it interim because we're still working through to see what, and further define what the right pressure level actually is, if any, to be frank, and to maximally protect brain health with that, along with the measures to limit exposures. The new requirements for data collection include baseline cognitive assessments to better understand blast impacts and preventative efforts. And then there's guidance, which I'm particularly excited about, of integrating blast overpressure risk considerations in the weapons design itself and in the acquisition process, and efforts to better equip our personnel to recognize the potential symptoms and know where to go for help. This policy stems from our ongoing research efforts, as you alluded to, and as new critical findings emerge, we use them to rapidly identify additional steps that we can take, and we don't hesitate to put them in action. The new policy is indicative of this approach, and we will continue to take. And we are not waiting to implement the new direction. I can tell you the DoD components are already working to update their policies and practices to align with those requirements. It was designed to spur concrete and immediate action. And as an example, all new active and reserve component accessions will undergo cognitive baseline assessments. That's already started, and by the end of this calendar year, at all of our accession sites, we will be doing the cognitive testing. This policy is one aspect of our overall strategy and a plan for warfighter brain health, but we also know there's much more to be done to protect our service members, and we welcome additional perspectives to inform the road ahead. So thank you again for the time and careful attention to this issue.
Well, thank you very much. Thank you, Dr. Smith, for joining us and for your statement. And I understand that's a joint statement from the Department of Defense, and that includes your statement as well. Is that right, Ms. Lee?
Yes, ma'am.
Good. Dr. Zafont.
Thank you so much. Good morning, Senator Warren. My name is Ras Zafont. I'm honored to have you here today and to provide testimony on traumatic brain injury and blast exposure for our warriors. Thank you, Senator, for convening this forum today and for being a champion for our nation's active duty military and veterans. My career is centered for years around people with traumatic brain injury and other catastrophic illnesses, and I'm privileged to serve as president of Spaulding Rehabilitation, but also as chair of the Physical Medicine Rehabilitation Department at Harvard Mass General and Brigham and Women's Hospital. For the past 15 years, I've also served as chief of traumatic brain injury at Massachusetts General Hospital's home base program, where I helped develop and oversee a comprehensive brain injury and polytrauma program including one that focuses solely on special operations community. This program treats heroes from across the country who often experience the highest level of blast, but also other extreme environmental conditions. According to the July 2024 Department of Defense report on the incidence of military suicides by job code, service members whose exposures to repeated blasts are high have among the highest suicide rates. Between 2011 and 2022, the DoD identified nearly 6,000 service members who died by suicide. Explosive ordnance disposal team members had the highest suicide rate, followed by infantry, missile guidance artillery, and armored crews. Now, clearly, suicide is a very complicated, multi-domain entity, but this exposure cannot be a good thing. In training and on deployment, special operations personnel operate heavy weaponry that exposes them to blast overpressure and mild to moderate traumatic brain injuries that may go undiagnosed, untreated, or otherwise not mitigated. Brain injury research is increasingly showing that blast injuries and other cumulative traumatic brain injury exposures can lead to a cascading series of negative health impacts that must be considered as we think about humans, a complex interaction of systems. Data from our colleagues, such as Dr. Edlow, who is here today, has shown the possibility of specific pathology and brain network changes associated with repeated blast exposure. But there's more than that concerns me. Yes, there's the blast and brain-related issues, and our data shows that special operators have higher rates of not only brain and health and behavioral issues, but cardiovascular health, sleep disturbances, sleep quality, pain, endocrine dysfunction, likely related to blast exposures, physical and mental trauma, other hazard exposure, and a life in this stressful scenario. The greater lifetime combat exposure, the higher intensity combat training with significant concussive exposures, and these highly kinetic missions of the special operations community means they are exposed to significant concussive and overall trauma events that do not parallel others. Some may be trainers with even more exposure to blast. Their lives are gained, and as I've said before, these wonderful people are the 1% of the 1%. Yet many wind up with lifelong problems, so-called maladaptation. Our own research with traumatic brain injury has shown an elevated 10-year risk of hypertension, cardiac disease, endocrine, hormonal dysfunction, and behavioral concerns such as depression, anxiety, and even bipolar disorder in patients without pre-existing diagnoses. Such work on cardiovascular risk has just been corroborated by a military research group. Medical comorbidities were observed in relatively young patients with traumatic brain injury, not just older service members. And recent reports, as you have stated elegantly, have suggested an unclear link to the concerning elements of additional neurodegenerative disease and even cancer. Now, the Comeback program was formed in 2018 at the very end, and modeled after programs that we had developed for elite athletes, but with a special focus that they're not the same, that these are different individuals with different exposure. The program provides coordinated, integrated, multidisciplinary specialist evaluation in an immersive fashion. It focuses on eval and treatment for the special operator community, and it leverages the depth and breadth of this remarkable research community at Mass General Brigham in Boston. Patients receive special evaluations for multiple medical specialties and therapies, and it's truly comprehensive. So when we think of somebody, Senator, they're not just a knee or a brain, or a human being, and we are all interactive. What we try to do is treat each part that is contributing to not doing. Since the combat program's inception, 600 special operators have completed it from 27 states. This is a national program. Yes, we're Massachusetts born, but we have a national and broad impact. There are 456 of the 600 were active duty, returning these people, as you said, to the fight. And currently, 135 operators have been screened and are waiting to be scheduled. That is the backlog. As someone who provides direct care to this population for years, I've seen firsthand the health issues associated with this special life and with repetitive blast exposure. Combat has uncovered cases of myasthenia, Parkinson's, and as you said, numerous head and neck tumors of which we are unclear of the etiology and are rather very concerned. Home base has been able to leverage our world-class environment to bring what is best in class to this community. So what's needed for the future? It's imperative that we do more research to better understand the impacts of repeated blast exposure over a long period of time. The impacts on the brain, yes, are also important, but the entire person just as much. And this research will have a real-world impact on force readiness and on the capacity of our military. The Special Operation Forces personnel experience intense physical and psychological demands that exacerbate health issues and reduce what I refer to as health span. That is the number of years we not really have life, but we have good health. We have our own personal agency. We can do what we want to do. It is the value in healthcare. While research has identified what issues really affect special operations personnel, it is still unknown why they are more likely to sustain a litany of medical complications, and more importantly, how to mitigate these. Home base has collected data for 5 years on psychological health, traumatic brain injury, and post-blast exposure in the special operations community. Along with our colleagues, we hope to leverage this existing data and experience working within the special operations community and the expertise of best-in-class researchers to springboard our understanding. So I really want to just talk for a second to our mission. This work in health span is all about keeping our forces healthy, having them have a different, not only lifespan, but burden of disease. And in some ways, it really means the duration of that they can do what is most meaningful to them, serve our nation, but they can experience what we all want. You do you. And service members have true agency. While we cannot change our service members' prior brain injury and bodily exposures, we have an opportunity to affect change and improve long-term brain and body health by identifying risk factors and creating methods to improve health outcomes. On August 8th, the Deputy Secretary of Defense provided Pentagon leaders for Combat Command's new requirements for managing brain health risks from blast overpressure. This is an extraordinary and excellent first step, and I applaud the DoD for this directive. We now need to treat and prevent what we can now, avoid unnecessary exposure, and measure things, while innovating further to create more impactful mitigation measures for our nation's hearings. Thus, we need a comprehensive approach. We look forward to working with the DoD to provide care to those already affected and most in need, while using the breadth and depth of our health system to build out research-based mitigation measures that the DoD can use to support all our service members. Thank you for inviting me to.
Thank you very much. Appreciate it, Dr. Zafon. Mr. Hernandez.
Thank you, ma'am. So, good morning, Senator. My name is Dennis Hernandez. I'm honored to be here today to share my story and advocate for the critical issue of blast overpressure and traumatic brain injury care for service members, particularly in those in the special operations field. I'm a retired Special Forces veteran with 22 years of service in the United States Army. My career took me to various countries, combat zones, and training events around the globe. Throughout my time in service, I was repeatedly exposed to blast overpressure from a range of sources, including being struck by multiple IEDs, applications of breaching charges, and various environments in which exposure was expected, if not guaranteed. One core memory is the first time I was struck by an IED. Training in the early days of the War on Terror taught about the signs of an IED and what to expect. One of them was when local populace would start being rushed out of an area that Americans had shown up in. I remember starting to tell the driver what was going on in this instance, but I never finished the sentence. The next thing I remember, I was waking up in a cloud of smoke, and the debris could only see the green glow from the radio frequency on the Humvees. I had just been on top of the vehicle as the vehicle's gunner outside of the turret. I never saw the IEDs we parked right next to. Luckily, only one of the 3 that were laid out had detonated that day. It created a lot of chaos and havoc and almost completely mangled the vehicle. We all survived, but that was the start of a very long career of being exposed to concussive injuries. In 1 year in Iraq alone, myself and my teammates were directly hit by over 20 IEDs, some more effective than others. These experiences, while an expected part of the job, took a significant toll on my health. After 13 years of active duty, I continued my service with the Massachusetts National Guard's 20th Special Forces Group. The cumulative effects of blast overpressure led to challenge that I, like many others, found difficult to navigate on my own. It has affected my physical and mental health over the years. I would black out at times and have no recollections of events that I'd participated in. These incidents would lead to feelings of confusion, frustration, and these would lead to feelings of anger and doubt, as if I wasn't in control of my own life. I tried approaching the VA and attempted to get assistance, but was very swiftly rebuffed by the doctors that told me, and I quote, "I do not meet the criteria for MTBI." I have been a part of studies at the VA that are working towards advancing the understanding of TBI with the TRACS program. And I have met some of the most caring and wonderful people in this program. That is not to say they aren't trying, but this was a research study, not actual getting assistance. So this was not the help I was looking for. After failing to get care through these channels, I was lucky enough to be referred to home base by one of the best leaders I ever served with, Sergeant Major Pete Smith. He referred me to the home base program, and I ensured I sought help through the home base's TBI program. The experience proved to be transformative for my health, well-being, and has put me forever in debt to him and the home base program itself. At home base, I received not only medical treatment, but also the tools to understand and help manage my injuries. The comprehensive care and support I received allowed me to take successful strides in managing and recovering from decades of exposure. This has been pivotal in my post-military life. Since my time at home base, I've had the opportunity to start my own company and pursue higher education, completing a master's degree in computer science at Northeastern University. If it weren't for the support I received from home base, I don't think any of that would have been possible. I'm truly forever in their debt. My journey has shown me the critical importance of the proper diagnosis, treatment, and support for those suffering from blast-related injuries. I stand before you not just as a veteran, but as a testament to the resilience and recovery that is possible with the right care. However, for every success story like mine, there are countless others who struggle in silence. I'm here today to advocate for those service members, to urge continued research, resources, and support for those that affected by blast overpressure and TBIs. Our service members deserve the best possible care, both in the field and when they return home. So thank you for the opportunity to share my story and the ability to recognize as well the people of the home base program, such as Dr. Zavant. He is my primary care. I see him a lot. Caitlin Kennedy, she's one of the nurses I interact with most often and my main point of contact at home base. And the very unsung heroes of the program that are not often mentioned, but also they're a vital resource for the veterans that participate in person. The veteran coordinators. These are the people such as Derek Goodwin that can turn to as a trusted source who have shared the experience and continue to serve us by working with the home base program and helping how they can. And I look forward to discussing how we can work together to improve the lives of those who have given so much in service to our country.
So thank you very much. Thank you, Mr. Hernandez. I'm very grateful to you, not just for your active duty service, but your service now in advocating on behalf of all those who have been exposed and who we may be able to help with avoiding exposure in the future. This truly changes lives, as you know. So the New York Times reporting in December 2023 revealed stories of service members with exposure to high levels of blast overpressure experiencing hallucinations, seizures, depression, heart and digestive issues, and more. Too often, service members wait until the end of their careers to seek treatment for exposure to blast overpressure. They may worry that taking off time to seek treatment will interfere with their career progression, or the prospect of scheduling a patchwork of doctor appointments may feel daunting and time consuming. So, Mr. Hernandez, if I can, I'd like to start with you. You spent most of your time in the Special Forces as a Green Beret, and after 22 years of service, you ended up with Home Base's 2-week intensive clinical program. So can I just ask about kind of the gap in there, and that is the challenges that you faced in receiving care, and then why did you eventually come to Home Base?
So I'd had some friends that had gone through the National Intrepid Center of Excellence, so NICO, mostly through the military government programs. They were all active duty, though. I was already off active duty and retired at the time.
So you're no longer eligible for the one program out there, or it?
I actually didn't know.
Not clear.
I didn't. I wasn't
Okay.
sure how to reach out. I was talking about it with my sergeant major, as I was referring to before, and he actually helped refer me to this because I had tried going to the VA, and as I stated, it was less than stellar experience. Right? It's a common story, little too common, but this is just one experience of many out of many good ones I've had at the VA. But this one just sticks out because of I was entering there looking for help with a problem, and the neuropsych that was interviewing me had walked in the room as if I was interrupting his day. I wasn't in there more than 5 minutes, told me I didn't meet the criteria, and just moved me along.
And I don't want you to say that you don't want to talk about, but can you say a little bit about the symptoms that were causing you to seek help?
Yeah, so I was forgetting a lot, and not just not remembering a specific detail, entire blocks of time. I was a penetration tester in my previous field, and I would actually test security for companies and corporations and ensure that their security measures work. There was one test we had run in the morning that in the afternoon when we were debriefing on it with video, I don't remember. And that was kind of one of the really last straws for me to start seeking help with Home Base, because it's just a really jarring, jolting feeling. There's video of you doing something that, for all you know, could be made up. There's evidence of people that were there, saying you were there, you said this, you did this, and doesn't exist in my memory. So that feeling isn't great, to say the least. But that is how I ended up getting referred to Home Base and talking to the people here, and then eventually doing the 2-week intensive program.
And Dr. Zafont, in your role as Chief of Traumatic Brain Injury at Home Base, you see firsthand the extensive damage that low-level and subconcussive blasts have on service members. What is the impact of a service member delaying assessment and treatment?
So, first of all, thank you, Dennis, for your service and your advocacy for other service members. Senator, thank you for that great question. And I guess I would say I'm worried about this issue with delay. People delay because they believe they need to be tougher. This is already the toughest group that we possibly could find. And then, as Dennis described, they delay sometimes because care isn't seamless. It isn't integrated. And these issues compound over time. Having more exposure, not getting treated, really leads to, as I referred to earlier, a maladaptive kind of spiral. You get negative on negative. You get pain on top of headaches, on top of depression, on top of the cognitive clouding that we just heard about. And it has family impacts. It leads to isolation. And we believe multi-system effects. So Home Base helps people get treatment, helps people get immediate access, and we want to provide more to more people. And really, I think, helps restore the fighting forces health.
So I just want to focus on this for a second. From the time, Mr. Hernandez, that you first started experiencing symptoms that had you worried and that told you, I need at least to be checked. I need to talk to someone. And the time you made it to home base, roughly about how long was that?
I would say from the first time I tried seeking assistance from the VA, maybe I went in 2022 to home base, so 5, 6 years.
5 or 6 years. And I'm hearing you say, Dr. Savant, that the more time that there's delay, that the symptoms can actually just continue to get worse. Is that right?
Absolutely, Senator. And what we want to do is get to people early, redress their issues, and try to mitigate what we can.
So if service members don't get the care they need when they need it, they have worse health outcomes overall.
We believe that their outcomes will be worse and that those outcomes may have broad implications for their quality of life. Yes.
I appreciate this because it matters in terms of some of the policies we think about in terms of access to care early on. But there's a second thing that home base does that I want to ask about, and that is not only providing incredible care for the service member or veteran, but also bringing the families in. Why is it, Dr. Zafant, that home base has focused on asking each, as I understand it, asking each service member who comes in or veteran who comes in to have a family member or close friend, a partner with them in this treatment?
Senator, thank you for the question. I think it comes down to the whole person, the whole life. When we think about ourselves, our families are key to who we are. They are our very core. Families are critical to doing a few things, one of which is supporting the person, making sure that they actually follow up, but also responsibility. As someone who clinically treats people, if your family member is in there with you, on occasion, they may tell a little bit more of the story than you may tell yourself.
Now, Mr. Hernandez is smiling while this happens.
And then I think families have an important impact on behavioral health, on people's functional status, and linking to any therapeutic regime we develop. Mm-hmm. So we are, in part, critically molded by the families we're a part of.
Yeah. I so much appreciate that home base includes this. And I take it, Mr. Hernandez, you're a supporter of this.
Absolutely. Yes,
Good,
ma'am.
good. So commanders agree that this care is critical. At a hearing earlier this year, the commander of Special Operations Command said home base is, quote, a blessing for your special operators, and that they see results when there is more access to care. So this is the reason that I'm pushing to secure federal funds to establish an intensive 4-year brain health and trauma demonstration program for service members to get treatment for blast overpressure, blast exposure, traumatic brain injury, and other common psychological or neurological conditions among service members. Dr. Smith, you're in charge of health readiness and protection for our service members. Do programs like Home Base that give service members access to efficient and effective treatment help promote readiness?
Thank you for that question, Senator. Clearly, protecting the health of our service members is one of my priorities, but the department's priorities. And ensuring the care to our service members helps not only them and their families, but also clearly is directly related to our readiness and our ability to do the missions that we're called upon to do.
I just want to underscore this. It is important that we honor our service members. That is morally the right thing to do, but it also just makes good sense.
Yes, ma'am.
On readiness, and that's the part I just want to underscore. You agree with that, Dr. Smith?
Totally agree with
Good.
you, ma'am.
Good.
And,
I'm sorry, and I interrupted you.
Oh, no. And as you know, our primary mechanism for access is through either the direct care system, which is the group of military clinics, hospitals that we have around the world, and or TRICARE, where we partner with partners across the world, quite frankly, to be able to try to promote that, promote access. But I can't endorse any particular treatment program, of course, as you know, but I do want to point out some of the great things that home base is actually doing. One very important piece that Dr. Savant and was evident from Mr. Hernandez's story is trying to promote people to come in early to get treatment. And the reality is what we see, it's typically later on in career. Now, that may be when they're starting to feel the effects more, but it's also, I think, what you had pointed out, that there's stigma associated with doing that. And so I think Home Base is an example, and a number of other organizations are doing a great job of trying to promote that specifically. Also, this partnership that we've been talking about that SOCOM, our Special Operations Command, has with Home Base, and the pilot that they're doing in this space, I think really has incredible value. And we're really looking forward to the data that they're capturing to be able to see the effect and what is working better than others. Where do we need to expand emphasis, take away emphasis? And I think this is exactly the kind of work that we need to be doing to be able to further this.
Now, I appreciate the Department of Defense's approach in partnership with Home Base and other organizations in order to try to deliver the best possible care, but also always going back to, we have got to do the research and get more data about what's going on. So I'd like to focus now, if I can, for a minute on the long-term impact of blast overpressure. The care that programs like Home Base provide are even more important given that service members may be dealing with symptoms for the rest of their lives. Mr. Hernandez, you believe that in addition to exposure from standard training and IEDs, that much of your exposure to blast overpressure also occurred because you were a trainer. That's what I'm told. So what types of long-term health challenges have you and your fellow service members faced after this kind of exposure?
So with those specific challenges, I've already mentioned the gaps in memory. I've noticed a lot of self-doubt, depression, anger. It doesn't always happen right away, but over time, when you spend enough time on teams with people, you notice the change in personalities. They'll start out as a happy, jovial person, and over time will become much sour, negative, depressive, and just generally angry. Unfortunately, in the military, most people turn to drinking to solve the problems, but that we've gotten a lot better over the decades in identifying that and taking care of it internally, referring externally as needed.
I very much appreciate your highlighting these challenges, and this helps add to the advocacy work you're doing. Other service members, such as artillery crews and mortarmen, have reported anxiety, depression, irregular heartbeats, headaches, difficulty concentrating. So there's kind of this constellation of responses that people talk about with this long-term exposure. Dr. Stefan, when you work with your patients, they face a variety of debilitating symptoms. What other types of long-term health consequences are you seeing in service members, and what are you concerned about possible connections here between blast exposure and long-term consequences?
Well, first of all, thank you for the great question, Senator. I think we're very concerned because we're seeing a number of different linked longer-term health problems that we need to study over time. These include, as you just said, behavioral ones, anxiety, depression, but things like attention and memory. A number of our folks are notable for chronic pain from musculoskeletal issues. And pain doesn't exactly make suicidality better, it makes it worse. We know heart health issues may exist, and the rates of everything from sleep apnea to hypertension to heart disease are elevated. And as we said before, and you noted, we have this concerning element of a link to cancer that we have to explore more. So I think there are a lot of long-term health concerns. We're getting good at identifying which ones they are. We now have to understand the why and how to mitigate it.
So let's talk a little bit about the why. What we've talked about now are observable symptoms, self-reported symptoms, some that you can see, and that we're starting to track some long-term consequences. Do these results surprise you?
In some ways they do, because of the broad and multi-system gravity of them. It's clear that we're concerned about links to long-term neurodegenerative disease. The ones that surprise people probably a little bit more are linkages that we, as I described and others have shown, to heart disease or cancer or to other multi-system injuries. As Dennis would probably share with us, carrying a rucksack or parachuting or jumping out of things, that's not so great on your back and shoulders and other entities. And so pain produces more sleep dysfunction, which might produce more brain dysfunction. And so we're concerned with the multi-domain nature of this and the need to really parse it out and understand it.
And have you examined the brains themselves? Have you been doing MRI tests and other kinds of tests on brains of special operators?
Yes, we have. We have serial MRIs being done on our combat operators. Our colleagues at MGH have done brilliant work looking at a multi-system approach to specific imaging techniques to find some of the abnormalities that appear linked to blast exposure.
So these are people who may not be symptomatic, but who are but who are united in their blast exposure, and you have seen at least evidence of brain malformations. What are you seeing?
We're seeing abnormalities in either network connection or specific areas of the brain. The why isn't as clear. I think what we really need to do is understand who these folks are, what the impact of the blast itself is, one side, what is the impact of all of the stress and the other parts of a life in special forces on the other side, and how that affects brain health and overall health.
Okay, so that describes a study of how people are right now, but to better understand the impact of blast exposure, what kind of a study do you need?
I think it's a great question, Senator. I'm a believer that we learn the most from a longitudinal study, from a long-term study characterizing and following people. Long-term studies do something incredibly important, such as Nurses Health or Framingham, that many of you may have heard of. They identify risk factors. They help us detect rare event things like head and neck tumors. They help us position the ideas to develop clinical interventions to help people. They allow us to predict health outcomes. They answer questions for the service members themselves about prognosis, and they strengthen our evidence for care.
So if I'm understanding this, it appears that we have people who are exposed, blast exposure, and then we have at least some preliminary evidence of changes in the brain, tumors, other changes in the brain. Stop me if I don't have this right.
Yeah, I wouldn't say brain tumors, although we haven't linked that, Senator. Colleagues from a large data set within another group have seen
But
brain cancer.
there is at least some early concerning evidence. Then a constellation of symptoms that start to show up and over time may get worse, and then ultimately things that may not show up for years,
Absolutely.
like cancer, Parkinson's disease, other connections that may be related to blast overpressure exposure. And I take it what you're saying is you've got to have some studies that reach out over a long enough period of time to be able to track the effects of blast overpressure. Is that a fair description?
Fair description, Senator. We need to follow people serially, keep them as part of a study group, and understand how they behave, not in the first few years, because many of them are younger, but are they being robbed of early middle life? Are they aging quicker in some ways? Are they being exposed to diseases that they might see in their 80s and late 70s in middle life?
Yeah. So, Ms. Lee, the fourth line of effort in DoD's Warfighter Brain Health Initiative is to, quote, reduce or eliminate long-term and late effects of brain exposures and injuries. What are the benefits to studying potential long-term health effects like brain tumors or other long-term effects in service members?
Senator Warren, thank you so much for your question, and thank you for highlighting the Warfighter Brain Health Initiative. And thirdly, thank you for your unrelenting efforts to secure funding in this space so that we can continue this very critical effort. So when we developed the Warfighter Brain Health Plan, Strategy and Action Plan, the comprehensive strategy and action plan, we have 5 lines of effort. And we wanted to ensure that we did have, even before you had brain threats or brain exposures, blast exposure in this case, all the way to understanding through traumatic brain injuries, exposures, injuries, all the way to a better understanding of the late and the long-term effects. People that suffer from comorbidities in conjunction with their traumatic brain injury, and then also later effects that have been found on brain tissue. So that's why we want to reduce and eliminate the late and long-term effects, looking at that. As we do so, and some of the previous lines of effort support and contribute to this goal by better longitudinal monitoring and mitigation of both risk exposure and cognitive and physical performance impacts. We have 3 major objectives in this line of effort number 4, and that's really to have a better understanding, as Dr. Savant mentioned, looking longitudinally at what causal factors, how to better characterize, how to distinguish between long-term effects versus the later effects that we've seen in some patients, and also to understand who does get those long-term effects. Not everybody gets them. So what's the discernment between somebody that does experience those very challenging and complex sequelae? Secondly, we want to inform proactive and evidence-based treatment and rehabilitation strategies and countermeasures to improve those outcomes so that we can influence and maximize quality of life. The benefit of studying long-term health effects is to support and improve service members' long-term functionality and quality of life. And we strive really to get to a point where there is no longer a line of effort 4. And finally, we have to do that. The third objective is with partnerships and with other federal agencies, including our VA partners, as well as private industry and others that can help us really achieve these goals of better characterization and understanding between exposures, how do those thresholds lead us to blast injuries, and then how can we mitigate this all up front, encourage people to come in and seek care, and eliminate, as I said. Hopefully we're not talking about a line of effort 4 in years to come.
I very much appreciate the work you're trying to do and hope that through this partnership we can do more of this kind of longitudinal study. Without more information, we will continue to provide good care here at home base, and I'm grateful for that, but we need better information about what's happening overall. So I'd like to turn to one more issue before we wrap up today, and that is to focus on understanding suicide risks related to blast overpressure. In late June, the New York Times reported that a military lab examined the brains of Navy SEALs who died by suicide and found, quote, distinctive damage from repeated blast exposure in every brain it tested. Let me say that again. Physical identifiable damage in every single brain it tested. Data show that the high risk is not limited to the special operations community. A congressionally mandated report found that suicide rates for troops repeatedly exposed to blasts were more than double the rates of the civilian population. One of the provisions that I secured in this year's NDAA requires DoD to establish individualized strategies for the military operational specialties that are at greatest risk for blast exposure. Dr. Smith, DoD's current suicide strategy does not address what we now understand to be true. Blast overpressure exposure is a major risk factor for suicide. Would service members at high risk for blast overpressure exposure benefit from strategies evaluating and addressing their higher risk for suicide?
So I appreciate the question. It is clearly true that we need a much better understanding of how blast exposures and associated brain injuries are connected to suicide risk. You hear the tragic stories, and it clearly, particularly with the service members taking their own lives, motivates us to act in this space. But I will say the connection between blast overpressure and suicide risk remains a very understudied area. And we need to collect and examine more, as we've been talking about, longitudinal data to scientifically determine whether and how blast overpressure may contribute to suicide risk. And I think you're probably also aware in January, the TBI Center of Excellence actually published a research review that looked at the state of science on TBI and other comorbidities, including suicide and attempted suicide. But I will also point out that all of this research that's been done typically sort of, this is a little strong, but has not taken blast overpressure into account in these studies, partially because it isn't easily measured, and it's a fairly new understanding that's coming into awareness. So again, it's understudied. But in that, it clearly was shown that TBI does appear to be, with TBI, it appears to have risk factors associated with suicide. It tends to be a higher correlation with moderate to severe TBI. Now, the reality is the data is really messy, and it's hard to actually support firm conclusions out of it. Also, as we talked about, it's often that when you have somebody with TBI, they also have other, what doctors call comorbidities, such as PTSD, depression, and those actually have higher correlations in the studies often than the TBI itself. But there's clearly substantial overlap between these various issues, and that's what also makes it hard to study. So in June, we did publish a report that looked at the various MOSs, as we've been saying, military occupational specialties, and we did see clearly military occupational specialties that have elevated risk. We also saw ones that don't have elevated risk to blast overpressure, but were high also. And so that just, again, reinforces the need to look at this and continue to support work to try to sort out what are the pieces associated with this. But while we're doing that, it goes back to making sure that we're working on the prevention efforts. We're working on trying to get individuals in to be seen earlier, because we know that there are effective treatments if they do that. And also, we've instituted the cognitive monitoring, which I think will help trigger that and help. So I hope that helps answer your question.
It is. And look, you'll never get pushback from me saying you want more research and want to understand a problem better, particularly in this area. But the early evidence is flashing red, and I'm very disturbed that our current suicide strategy does not aggressively take into account the possible links between blast overpressure exposure and suicide risk. So this is the part I just want to make sure we keep pushing this out. We can't wait until we finished all the research and said, and now we're going to turn to this problem. In fact, let me just ask you to weigh in on this, Mr. Hernandez. What is your sense? Do you think it would be helpful to bring in more service members into the who have had blast overpressure exposure?
Oh, absolutely, ma'am.
Go ahead.
No, it's kind of a loaded question too, right? We don't have enough time
What?
to talk about this.
Yes.
Right. There's a short answer and a very long answer.
Okay. All right.
So the short answer is there needs to be a lot more open, ongoing dialogue between leaders and soldiers, free from repercussions, stigma, anything like that. Additionally, it's really important, as you've stated already, that the government support increased research in the links between TBI and suicidal ideation. In addition to the comorbidities that have been discussed, there's a lot more that can be looked into for the links between them. Military has kind of a long history of paying lip service. Now we're going into the semi-longer answer, right? The military has a long history of paying lip service to its members, stating, no career-ending, ruining actions can be taken if you seek mental health assistance. That's crap. Everyone knows it. Everyone in the military will absolutely, most won't tell you, but they'll tell you exactly what they see. We've seen it time and time again. Soldiers seek mental health, they immediately become stigmatized. We've done a lot better job over the years of taking that stigma out, but it's a generational effect. The military has done the right thing by starting this process and taking that stigma out. We've initiated peer counselors, master resiliency training. Even some organizations have psychologists at the unit level. So we're doing a lot better about it, but there's a lot more could be done because there's always a pervasive group of people in the military whose battle cry is always, this isn't how we used to do it. Well, great. It's called progression. So with them, I'm not saying they're bad people or bad soldiers or service members. They just are stuck in that way. And sometimes you can't train old dog, new tricks. So one person's opinion, it's a generational defect. We need to allow those soldiers to retire, and as we're training the new generation, bring them up with the proper techniques and abilities to mitigate this and help. I'm not saying don't train the old soldiers, but no matter what we do, a lot of the stuff in the military is check the box. We did this training, great, I saw that PowerPoint. Somebody talked to me for an hour that I didn't pay attention. Box checked.
Yeah. Well, I appreciate your perspective on this. You know, I am glad to see the military take a much more active role on suicide prevention and start to take this issue more seriously. I'm obviously concerned that the blast exposure risk factor does not seem to be weighted into the overall strategy yet. You know, even the Department of Defense's own suicide prevention office has said that, quote, patients who have experienced a mild TBI have a twice as high risk of suicide than individuals without mild TBI. I cannot understand why DOD would delay even a day in working on plans to identify and reduce risks stemming from blast overpressure. That's my urgency at this moment. Also, education is critical. Lieutenant David Metcalf, a Navy SEAL who died by suicide, left a suicide note that described, quote, gaps in memory, failing recognition, mood swings, headaches, impulsiveness, fatigue, anxiety, and paranoia were not who I was, but have become who I am. Each is worsening. That's his suicide note. The spouses of those who have died by suicide usually may know something is wrong, but it can be difficult for them to figure out what is wrong and how to fix it. In the wake of this tragedy, his wife, Jamie, launched a grassroots effort by families for DOD's Brain Tissue Repository Lab to study the brains of others who have died by suicide. Ms. Lee, why is it important for the Department of Defense to help educate families of service members about recognizing and understanding the symptoms of blast overpressure?
First, ma'am, thank you so much for sharing David and Jamie's story. We too have learned and read of David's suicide note. It's very compelling. It's a motivator. Quite frankly, to tell you, I have it on my desk. I keep it with me every day because it's a motivator for us to push forward as rapidly as possible. It may not be the 100% solution, but the 80% solution to get out the door so that we can help folks. It is an important question about why we should be educating family members about this topic. Recent research has shown that social integration and support, including connectedness to your family, can be a protective factor against suicide. So we need to treat the families as a solution, as part of the solution. As we mentioned before, a core priority is getting families to come in for early detection as soon as those symptoms arise or as soon as they believe that there could be an injury, as well as for mental health concerns. And families can help with both those dimensions. They can spot the symptoms when they happen and then also encourage loved ones to come into care. So family education is paramount. And even with high quality care, support from the loved one is critical to help support as they're navigating the whole traumatic brain injury recovery schematic. Educating families can help them prepare and help them through that recovery and also enhance patient outcomes. So we too believe that that is very crucial to make sure that we're educating. The department in December stood up a Warfighter Brain Health Hub. So all this information concerning cognitive performance and blast overpressure and head impact research, traumatic brain injury and the late and long-term effects, all that is collated on one site so we can keep the best up-to-date information. So I encourage all in this room and all to go check that out for best practices and what we're learning as soon as we know it.
And-
Health.mil.
Yes, and I appreciate that. You know, I want to focus, though, on the work of the families. I so much appreciate the work that they have undertaken, but we can't leave this on the families. And I want to come back to this question of research and how it is that we get the kind of research we need. And I think you mentioned, Dr. Smith, earlier in the answer to one of my questions about how we need, it's very hard to study because we don't actually have good information on who has been exposed, how much they've been exposed, what the early impacts were, what your baseline was before there were problems. Dr. Zafont, I had gotten into an earlier NDAA, a Blast Overpressure Safety Act, and now the DoD has issued a response. Components of the DoD will now be required to conduct cognitive baseline assessments for service members, which provides a starting point to compare and track changes in service member brain health over time. And just last week, the Army started conducting assessments at Fort Moore, where about 60,000 soldiers are trained every year. Dr. Zafont, I was hoping that maybe you could explain a little bit about why this baseline assessment is a good start, but whether medical providers would benefit from seeing more frequent assessments of service members' cognitive health, including perhaps a full evaluation before they leave the service?
Well, thank you, Senator, for your advocacy, and I think learning of that news, we all smiled.
Mm-hmm.
I can't emphasize enough of having a person's baseline. Knowing where they are is critical to knowing where they're going. And serial assessments allow us not only to identify factors for that person, but over time to think about prognosis for others or who we might intervene on early on. So serial measures are critical to what we want to do. The other thing to consider, and I think Dr. Smith brought this up, as have others, we need to know who somebody is to understand their path, to understand their unique path, to understand their exposures, and use various presently measured metrics of exposure, but also think about design of getting better at measuring exposure.
Yeah, I appreciate that. I want to wrap this up, but I really do want to underscore here that the Department of Defense's new memo shows that it has the authority to mandate these assessments. And baseline assessments are crucial, but they are only a starting point. We need more assessments as people progress. Some may need even more assessments, and we need assessments before people leave active duty military. And this is essential both for the research and just to make sure we are actively treating those who need it most. Dr. Smith, did you want to add something on that?
Yes, ma'am. I think we
Please.
wholeheartedly agree. And as you know, we have set it up to where it is repetitive. We've been doing baseline testing for folks that deploy since 2008. So the good news is we have that information. But now we're going to have it on everyone, and we're going to do it. The plan right now, it depends on the organization, but at a minimum at 5 years, because that's the stability that we've seen in the testing that we have. But some are likely to go sooner. And then, of course, whenever there's an event, that would be another trigger where they would potentially have, and that's the whole point of having these, is to be able to compare it to where they were before they had the event. So
I very much want to see this as a routine part of screening our active duty military. When they come in the door at determined intervals in between, if specific events have happened, and when they leave active duty service. That has to be a part of what we do. And we need to keep those records, and we need to keep records on exposure. So I'm going to keep hammering on this. I appreciate that you're moving in the right direction. I want us to move there faster and with shorter intervals on the testing. I want to thank all of our panelists for coming to today's forum. I also want to thank Home Base for hosting our conversation and Spaulding Rehab for providing the space to hold this discussion. I am proud to support the incredible work that you do here in Massachusetts for service members and veterans, and I will continue fighting for more resources for programs like Home Base that provide critical care, that help get service members back into the field, and that engage families directly in care. It is also important to examine other long-term consequences of blast exposure. I am concerned about the early evidence of specific brain abnormalities as a result of blast exposure. I am concerned that we have preliminary work here. That is all the more reason to put more resources in and do the larger studies that we need in order to determine clearer connections between blast exposure and possible medical consequences. We need more definitive studies to determine exactly what's going on. We owe it to our service members and their families to do this research so that we can better protect our service members from risks. DOD has a responsibility to do even better, to understand and address the risks and the links between blast overpressure exposure and suicide. We also need to do a better job of educating our families so that they can help support their loved ones and identify symptoms and help people get the assistance that they need. The DoD's memorandum is a big step in the right direction, but more is needed. The work on blast exposure and traumatic brain injury is critical to upholding our responsibilities to those who volunteer to serve our nation. It is the minimum that we owe them to understand what is happening when they are exposed and to give them the care and support and treatment that they need if they have suffered from that exposure. I am grateful to everyone at Spaulding. I am grateful to everyone at home base. I am grateful to our Department of Defense for all that you're doing every day to try to support our active duty military and our veterans. And I am particularly grateful to you, Mr. Hernandez, for getting out there and advocating. Nothing has an impact like telling a personal story. Nothing has an impact like having been there and being able to say to others who may be suffering from some of the same symptoms, not just identifying that you have a problem, but the real hope of home base, and that is there's treatment for these problems. We can help, but we can only help if we can get people in the door and we have enough knowledge about the most effective treatments over time. So thank you all for your work. Thank you to all of you who came. We make this a part of our public record, and believe me, it will be part of our next round of discussions on the Senate Armed Services Committee. So thank you all for being here today. Thank you.
Thank you, Senator.
Thank you.